Morning, everyone. Myself, Dr. Sagar Makhija, Assistant Professor in Index Medical College in Skin Department. So, my today's topic is cutaneous drug eruptions. Introduction. We'll start with the introduction, then pathogenesis, classification, types of serious and non-serious drug reaction, common drugs causing ADR. So, what are the examples for non-serious drug reactions? This includes urticaria or angioedema, fixed drug eruption, lichenoid drug rash, maculopapular rash, photosensitive rash, erythema multiforme, acneiform drug rash, and pigmentation. And the examples for serious drug reactions are SGS-TN, DRESS, anaphylaxis, erythroderma, and acute generalized exanthematous pustulosis. Introduction. So, it is seen in around 5% of the population taking drugs, and 2% are serious, also known as serious cutaneous adverse reactions. Definition: unwanted reactions that are not characteristic of the desired pharmacodynamic effects and predicts hazard for the future administration and warrants prevention, specific treatment, alteration of dose, or its withdrawal. Classification based on the mechanism can be non-immunological or immunological. Non-immunological is more common, 80%, which is predictable, dose dependent, affecting people taking drug at sufficient dose. And immunological is less predictable, 20%, not dose dependent, appearing after the latent period for the induction of immune system. Any drug which acts as an antigen will activate the antigen presenting cells. Along with some HLA epitopes, it will activate the T lymphocytes, and finally the T lymphocytes, CD4 and CD8, will release the cytokines like TNF alpha, interferon gamma, which will cause skin rash and epidermal detachment. According to the severity of prognosis, first type is simple, benign, or non-serious, involving only skin, no internal organs. Maculopapular rash is most common, self-limiting, localized fixed drug eruption, photosensitivity, acneiform eruption, lichenoid eruption, pigmentation, hair loss, or stripe. And second classification includes severe cutaneous adverse drug reaction, also known as SCAR. It is poor prognosis. It involves serious skin damage, internal organs, requires hospitalization, and can cause significant morbidity or death. It includes erythema multiforme major, Stevens-Johnson syndrome, toxic epidermal necrolysis, drug rash with eosinophilia and systemic symptoms, also known as DRESS, acute generalized exanthematous pustulosis, generalized fixed drug eruption, anaphylaxis, and erythroderma. Another classification is can be also known as Rollins and Thompson's. Type A is dose related or anticipated. Type B is non-dose related or bizarre, as seen in penicillin rash. Type C is dose and time related. Type D is delayed effects, seen in thalidomide. Type E is end of use due to withdrawal. And type F is failure of therapy. So in a severe cutaneous drug reaction, you can see facial edema, mucosal involvement, bullous skin lesions, skin necrosis, purpura, systemic symptoms like fever, malaise, pharyngitis, wheeze, arthritis, hepatitis, breathlessness, eye and tongue swelling can be seen in anaphylaxis. So what are the high-risk subjects for adverse drug reaction? Can be patients on polypharmacy, multiple drugs, history of any drug rash or allergy, family history of drug reaction, as seen in anticonvulsants, patients with autoimmune connective tissue disorders, immunocompromised patients in certain viral infections, HIV, HBV, and renal and hepatic involvement. There is strong Genetic predisposition to develop serious drug reaction in cases of DRESS, SGSTA in certain patients. So, presence of viruses like HIV, CMV, AIDS, HIV virus, they have a 100-fold risk to develop drug reactions. What are the most common drugs causing drug reactions? This group includes around 75%, which is sulfonamides, antibiotic, NSAIDs, anti-epileptics, allopurinol, antihypertensive, anti-malarials, anti-tubercular, and antiretrovirals, mainly nevirapine. Difference between benign rash and severe cutaneous drug rash. So these are all the examples which I've seen. Now, first is the maculopapular or xanthomatous rash. This is the most common drug rash. Begins within 1 week, lasts for 2 weeks. Itchy, discrete, or confluence, symmetrical, often begins on trunk and spreads peripherally. Most self-limiting rash can progress to severe conditions. Drugs causing are penicillin, sulfonamides, anti-epileptics, and antiretrovirals. Watch for the warning signs like high fever, facial edema, purpura. A close differential diagnosis is infectious exanthem. Appearance of lesions first on the face, then cephalocaudal progression, associated fever, conjunctivitis, cervical lymphadenopathy, moving towards viral infective rash. Urticaria or angioedema is the second most common rash. This transient edematous itchy erythematous wheals subside within 24 hours. Angioedema is deeper, mucosal, last longer, can be painful, may be a part of anaphylaxis, may involve Ig mediation or direct mast cell degranulation. Angioedema is common with AC inhibitors and can be fatal. Drugs causing urticaria angioedema are aspirin, NSAIDs, penicillin, ACE inhibitors, radio contrast media. This is the classical picture of urticaria with angioedema. Next is fixed drug eruption. These are circular macules or plaque with sharp borders. Healing with hyperpigmentation is characteristic. Lesions usually recur on the same side upon re-administration of drug within 30 minutes to few hours. This is the characteristic point. Common sites are hand, feet, lips, genitalia, usually localized. Unusual variants are bullous, linear, and non-pigmenting FD. Drugs causing are sulfonamides, NSAIDs, fluoroquinolones, most common, metronidazole, ornidazole, or tetracyclines. This is an example of fixed drug eruptions, mainly seen by cotrimazole or ofloxacin. Mucosal FD and bullous FD are the rare types. Lichenoid drug eruption resembles lichen planus, but it differs in being more extensive, less frequent mucosal involvement, and appears more psoriasiform. There are certain drugs like chloroquine, gold, antihypertensive, beta blocker, NSAIDs can cause this. Histologically, focal parakeratosis, exocytosis of lymphoid cells in the upper epidermis, and eosinophils in the dermis can differentiate. Photosensitive drug rash present with sunburn-like reaction. Drug may be continued in low doses, and patient is advised to avoid sun. Drugs can be NSAIDs, quinolone, naproxen, which are phototoxic drugs. Also, tetracyclines, amiodarone. Seen characteristic photo-exposed parts due to tetracycline, doxycycline, and also due to thiazides. Next is the erythema multiforme, characterized by typical target lesions. And lesions are distributed acrally and symmetrically. Infections such as herpes simplex virus, mycoplasma are more common. Mucosal involvement affecting oral cavity and eyes can occur. Drugs are also can be anything, including tetracycline, rifampicin, NSAIDs, nevirapine, thiazides. This is the characteristic target lesion over the forearm, seen in erythema multiforme, and hemorrhagic crusting, seen in extensive cases. Acneiform eruption, monomorphic lesions, papules or pustules seen mainly on the trunk and upper extremities. And absence of comedone differentiated from acne vulgaris. Corticosteroids are the most common drug. Apart from this, phenytoin, Isoniazid, oral contraceptive, and androgens, vitamin B12, lithium can cause. This is very important. Targeted chemotherapy, including epidermal growth factor inhibitors like cetuximab, can cause these eruptions. This is the classical picture of acneiform eruptions. Next is the pigmentation. Drug-induced pigmentation can be due to increased melanin synthesis, like drug or drug deposition in seen in clofazimine, or a post-inflammatory phase. Sun exposure will aggravate it. Minocycline, amiodarone, antimalarials like hydroxychloroquine, zidovudine, gold and silver salts, clofazimine are the most common drugs causing pigmentation. First picture is of minocycline. Second is zidovudine, classically seen in HIV patients. And third is clofazimine-induced pigmentation. These are the rare types of other morphological eruptions like erosia, psoriasiform, hypertrichosis, mainly seen in corticosteroids or cyclosporin monoxidil patients. Alopecia is classically seen in chemotherapeutic drugs. Now the next topic is Steven-Johnson syndrome and toxic epidermal necrolysis. Less than 10% is SGS, 10 to 30% is both SGS-TN, and more than 30% is TN. It is a spectrum of serious drug reaction characterized by widespread epidermal and mucosal necrosis along with multi-system involvement. SGS has a mortality of 5% and 10 has a mortality of around 30%. Drugs are anti-epileptic, antiretrovirals, sulfonamides, fluoroquinolones, and aminopenicillins. Sudden onset with prodromal symptoms like fever, malaise, arthralgia, followed by mucosal and cutaneous involvement in the form of skin tenderness, purpura, bullae, are typical target lesions, and subsequent peeling of skin in large sheets, also known as positive pseudo-Nikolsky sign. Severe mucosal involvement, oral, ocular, genital, tracheobronchial, esophageal can occur and affect feeding, breathing, and vision, and may lead to long-term complications, particularly in the eyes. Complications such as septicemia, fluid and electrolyte imbalance, respiratory failure, renal failure, and GI bleeding can occur, and this can cause death. Prompt stoppage of offending drugs, supportive treatment, and specific therapy like corticosteroids, high dose for a short period, cyclosporin, IVIG, and TNF alpha blockers are useful. So, in such cases, cyclosporin is seen to be the fastest acting drug. This is a classical picture of mucosal and as well as cutaneous involvement, characteristically involving the lips, hemorrhagic crusting. And second picture is of widespread necrosis of skin, seen in TN. So, next one is a drug rash with eosinophilia and systemic symptoms, also known as DRESS, also known as DIS, that is drug-induced hypersensitivity syndrome. This life-threatening idiosyncratic drug reaction characterized by a triad of fever, skin involvement, and internal organ involvement develops 2 to 6 weeks after the drug intake, mainly seen in dapsone patients taking dapsone. Begins at generalized maculopapular rash and then progress to erythroderma. Facial edema is characteristic. Eosinophilia, atypical lymphocyte hepatitis, and lymphadenopathy are common. Reactivation of HSV6 virus can lead to prolonged clinical course. Steroids are usually required for longer period of time, 3 to 6 months, and should be tapered. SLE, diabetes, thyroid disorders may develop as a late complication. Phenytoin, carbamazepine, lamotrigine, dapsone, sulfonamides, minocycline, allopurinol, nevirapine, and NSAIDs can cause this reaction. Anaphylaxis is a life-threatening acute systemic allergic reaction, IgE mediated. Early warning signs include faintness, skin tingling, and reddening of bulbar conjunctiva. Later followed by flushing, urticaria, angioedema, bronchospasm, abdominal pain, and vasomotor collapse. Penicillin, cephalosporins, radio contrast media, animal sera, aspirin, and other NSAIDs can cause such reaction. Erythroderma is severe exfoliative dermatitis involving more than 90% of the body surface area with erythema, edema, and scaling. Lead to systemic and life-threatening complications like cardiac failure, fluid and electrolyte imbalance, loss of thermal control, and sepsis. Anticonvulsant chloroquine, lithium, sulfonamide, nevirapine can cause drug reaction. This is a classical example of INS, that is isoniazid-induced erythroderma.
लगा आप 100 पे कितना बोल दिया था आपने?
Almost.
ठीक है, देख लेते हैं कितना होगा। अब कौन सी स्लाइड पे देना?
इतना स्टॉप कर दो
सर हम तो काफी स्लाइड पे शायद रिज्यूम हो जाएगा सर एक मिनट। हाँ सर अभी एंड में थोड़ी ना किया आपने। सर रिकॉर्डिंग स्टार्ट हो जाएगी दोबारा, ये चालू है।
Next topic is acute generalized exanthematous pustulosis, seen by a sudden appearance of sterile non-follicular confluent pustules seen over the face or flexures, accompanied by leukocytosis and fever. May be confused with generalized pustular psoriasis, developed within few hours to days of drug intake, like 2 to 7 days. Tetracycline macrolides are most common. Now the last part is how we diagnose adverse drug reactions. We should take the history of drug intake, sudden onset, erratic, bilateral, symmetrical, and it should subside on withdrawal. Evaluation of patient. Keep a high index of suspicion, history of drug intake and temporal correlation with rash. You can de-challenge or you can re-challenge. How to manage it and how to prevent further episode. History, a thorough history is very important, which will include onset and progression of rash, duration, complete drug details, interval between drug introduction and rash, past history of any drug reaction. Examination should include body surface area, morphology of lesions, mucosal involvement, blisters, skin necrosis, purpura seen in 10, facial edema, high fever, sepsis seen in breast, angioedema include breathlessness, eye or tongue swelling. Lab investigations are not so important. Serum tryptase level in anaphylaxis and skin biopsy used in articulated vasculitis and lichen eruption. How we will manage such patients? Withdrawal of the drug is the most important approach. In milder reaction, a close observation and treat symptomatically. How to manage adverse drug reaction? Non-specific therapy depends on the type and severity of rash. Milder rash can be managed with emollients, with calamine lotion, with or without topical corticosteroid, antihistaminic. For severe drug reactions like GSTN, systemic steroids, cyclosporine, and IVIG are used. Antivirals may be added if viral reactivation is suspected in breast. General supportive measures are very important in serious drug reactions, like monitoring of pulse, BP, respiratory rate, temperature, fluid and electrolyte balance, thermoregulation, prevention of sepsis. Maintaining nutrition and mucosal care. Treatment for anaphylaxis, you have to stop the drug, check the airway, BP, O2 respiration, injection adrenaline 0.2 to 0.5 ml 1 is to 1000 units. Injection chlorpheniramine maleate 10 milligram. Injection hydrocortisone 250 milligram IV or prednisolone 40 milligram per day for 2 days. I will prevent always avoid further exposure to the positive drug and issue a drug alert card to the patient and ask him to carry it with every time. Pharmacovigilance is very important. Summary, any drug can cause reaction. It can mimic any skin disease. Anti-epileptics, antibiotics, and analgesics are most common drugs. Withdrawal of the drug is the most important part in the management. Avoiding susceptible and chemical reactions is also important. And reporting such reaction to the competent agency, that is pharmacovigilance, is also very important. Thank you.